Right.
of a regular series,
Right.
which I think will be of interest.
Right.
The purpose of this series is to bring ear, nose, and throat medicine to the attention of
Right.
our listeners.
Right.
Yeah.
Yeah.
I am speaking with Professor Swetha Shankar. Swetha,
Yes.
can you introduce yourself briefly? So, what's your background? And I know that you have a vast experience and have
Right.
done thousands of surgeries.
Yeah. So I'm Dr. Swetha Shankar, assistant professor actually. I have working experience in India post my post-graduation for about 6 years, and I moved to Dubai nearly a year and a half ago and working with the very best Dr. Marc Mueller.
But what did you do in India? What kind of diseases?
So we had a wide range of diseases, as you know, the population of India. So a lot of complicated ear cases like cholesteatomas, CSOM of the mucoid type, voice disorders, voice polyps, cancers of the throat, cancer of the ear. Then in the nose, the functional aspect of the nose coming to deviated nasal septum, fungal infections of the sinuses, and the mucormycosis post-COVID.
So you have everything in India.
Yeah.
And there were so many words that probably people don't know.
Right.
So today, is there a special topic that you would like to talk about today?
So I actually had a very interesting case a couple of weeks ago. So I would like to discuss that case today.
Yes.
So I had a young male, 27-year-old. He had come with sudden hearing loss. So he said just since 2 days, he's not able to hear anything after going to a pub which had very loud music. So he had come to the clinic, and after we did a pure tone audiometry, it basically showed moderate to severe sensorineural hearing loss.
Okay, calm down.
Yeah.
So now let me translate that for everyone.
Yeah.
So somebody came to you and said, I cannot hear anymore.
Right.
On both ears or on one ear?
One ear, the right ear. Yeah.
So he was a man?
Man, absolutely.
How old?
27-year-old.
27-year-old
Yes.
man. Oh,
Yes.
This is very uncommon.
Exactly.
That you can't hear anymore.
Exactly.
So how did he notice this?
So he said he is involved in the business wherein he attends a lot of calls. So while using the headphones, he felt he was not able to hear on one side, but the other side he can hear pretty clearly. So the good thing is he came within the window period that we say. Yeah.
All right, good. So that we come to this. So
Yes.
people should come, when they feel that they cannot hear on one ear.
Absolutely.
You wouldn't know. It can be something harmless. Can
Exactly.
it? What could it be?
It can be. So, like in his case, based on the history, it was that he had gone to the pub and the music was really loud and it suddenly happened. So, it can be that sudden loud exposure, or it can also be a viral infection when they develop this sudden hearing loss. Or in some people, gradual progression of the hearing loss can happen if they are around areas that has loud noise exposure.
But to be honest, in my clinic,
Right.
the vast majority of people who say that they suddenly cannot hear in one ear have just wax in the ear.
Yeah, that's possible too. Yeah.
They went to the swimming pool and they have wax in the ear.
Right. Yeah.
And then a larger number also has liquid behind the eardrum.
Right. Fluid behind
they
the
had
ear.
some kind of a flu before and then they developed it. But your patient, he had none of this.
None of it. So because usually when they have wax or fluid, they notice a progressive worsening. So it starts from we couldn't hear a bit and then it's gradually worse. But he just said he just couldn't hear. Like suddenly he just lost his hearing. So yeah.
So that is dramatic, yeah?
Exactly.
And he came the next day, or?
He came after a day and a half to 2 days. So he was within that golden window period.
Yeah, why do you think he didn't come instantly?
So he thought that, he was exposed to the loud sound and in a day or two it's just going to get better. He's going to be fine. So he waited. When he saw that it's not getting better, he came to the clinic.
Are there any symptoms that people can expect that come along with that? Not only hearing, loss of the hearing on one side, but other symptoms?
They can have the ringing sound in the ear. So
like a high-pitched
Yes, like a high-pitched beeping. So, in some people it presents like a whooshing, in some people like a telephone ring, like keen kind of a sound. It varies, but yes, some kind of sound.
And that was in the same ear for him, or he
both were in the same ear. So in the right ear he had the ringing as well as the hearing loss, both.
And anything else that can sometimes happen with people when they have this, like dizziness or so? Can they have this?
It can happen, you know, if they have neglected it for a longer time and it's affected the balance organ as well, they can have the dizziness as well, yes.
But not so much with acoustic trauma?
No, not so much with noise-induced or acoustic trauma,
yes. So he had this acoustic trauma.
Right.
I think we all know this. If we go to a concert or so, and then when we go to bed, finally we lie in the bed, and then there is this high-pitched noise, and we have this experience that it goes away by the next day. Yeah. But for this guy, it didn't. It didn't go away.
It didn't go away. Yeah.
And he felt that he couldn't.
Yeah, he couldn't hear.
So what did you do then?
So he came to the clinic. So the first thing is we assessed to know how bad the nerve loss is, hearing loss. So it was moderate to severe, as I had discussed in the beginning. So once we got that, I gave him the option of the treatment protocol. So I told him he needs to go on intratympanic, that is through the eardrum we inject the steroid a combination of oral steroids, both. So this basically acts as an anti-inflammatory and reduces any kind of inflammation that's there in the nerve, and the hearing, it actually says that when you come within the window period of 72 hours, the hearing can go back to normal.
So here we need to explain a little bit, like, what Professor Swetha suggested for him is a treatment with cortisone. Cortisone, and a special form from cortisone, and also a special location where you apply the cortisone. Cortisone is a medicine that reduces inflammation.
Right, absolutely.
Why would you reduce inflammation after sound exposure?
So what happens is, as a protective mechanism, many a times the cochlear nerve, which is starting from the cochlea, gets inflamed. So due to sudden exposure to loud sound as a protective mechanism, but when it doesn't return back to normal, like you said, you know, in a day, many a times after we go to a concert, it comes back to normal. Yeah. But in some people, it doesn't, and the steroid aids in that. Yes. And it also, the blood vessels that are surrounding the nerve, it increases and causes vasodilatation, that is expansion of the vessels to increase the blood flow to the nerve.
So that's the effect of the steroid.
Yeah.
And we use some special steroid.
Yes, so
the crystalline.
Yeah, there are two forms actually commonly available. One is you can use dexamethasone, or you can also use triamcinolone acetate. So that in the concentration of 40 milligram per ml. So 1 ml is injected through the anterior-inferior quadrant so that it goes into the round window.
Yeah. So this is now very technical. So what she actually does is she looks into the ear, sees the eardrum, tympanic membrane, and there the tympanic membrane is round, and because it's round, everything that is round like a cake has quadrants. Yes. And we say there is a certain quadrant where you can go with a needle, you can stick the needle through the tympanic membrane, and then obviously the end of the needle reaches inside the ear. It's in the middle ear.
Middle ear, yes.
It's not in the inner ear. The inner ear is further away.
Yes.
But you want to be, because the disease is actually in the inner ear, you want to be with your cortisone, you want to bring it to a place where the connection to the inner ear is the easiest. Yeah. And you know that correct position of the eardrum, which you just described as anterior-inferior quadrant. Yes. And there's also very safe to inject there, by the way, because you have a lot of space there.
Space there, exactly.
And you can inject 1 ml.
1 ml, yeah. So usually it works that they need a minimum of 4 sessions, but it can go up to 6 sessions. So every week, they're called every week, 1 injection. And what needs to be kept in mind is there's a common practice that, you know, as soon as the injection is put, some people just get up. But the affected ear has to be turned up and they have to lie down for at least 20 to 30 minutes to allow for the absorption.
Yeah, so this allows the cortisone to migrate into the inner ear.
Exactly.
Into the cochlea.
Yes.
And This is the gold standard treatment.
Exactly, yes.
So after you have made sure that he cannot hear well and that there is no other reason.
No other reason, exactly.
You did this treatment.
Treatment, yes. And already 2 weeks, just with 2 doses of injection, he's already saying that 50% of his hearing is back.
Wow.
So he says he can assess it because he uses headphones at work. So he says I can already hear now from my right ear. So he still has another 2 sessions left.
Ah, okay.
Yeah.
So he's not yet 100%.
Not yet 100%, but at 50%. Yes.
So what is the takeaway message from that?
So the main takeaway message in this is that, if you're anytime exposed to a loud sound, or, you suddenly lose your hearing, not gradual, but suddenly, don't wait for too long, to go to an ENT specialist. A day maximum, because if you come into the window period and fit into this criteria, you can get your hearing back. So you don't have to be permanently deaf. So it's that golden period, you have to go to an ENT specialist in that period.
That reminds me of one incident that I had in my very, very first time as a resident.
Okay.
As residents in the hospital, you need to do night shifts.
Right.
And there was somebody coming at 1 o'clock
Okay.
in the morning, and I did not my alone night shift.
Okay.
It was really the first week.
Okay.
Yeah. First week, I had no clue about ENT at all.
Yeah.
And I had to go with a senior guy.
Okay.
Yeah? So we were called out of the bed and went to the emergency room where the person had arrived that couldn't hear in one ear, like your patient. And my senior resident checked the ear and saw it was full of wax.
Okay.
And then he started shouting and was very angry.
Okay.
And he was very upset and told me how the people can wake him up with just wax in the ear.
Yeah.
And I was thinking at that time, he's not a specialist, this patient. How
Yeah.
can he know that it's wax?
Yeah.
How can he know that his ear fell closed now just from wax?
Yeah.
That's it's the task of the doctor to figure out.
Exactly, yeah.
And that's why it's just still in my mind. Yeah, so you can lose your hearing all of a sudden for various reasons, and you don't have to be afraid what it is.
Yeah.
But the point is that that you need to check it. That you need to go to a doctor who can then say, it's nothing. It's
nothing,
okay.
Yeah.
Don't worry. It was just wax.
Yeah.
Yeah.
Absolutely.
Or somebody who is, or he finds or she finds that you have a sudden hearing loss, and then you really need to be lucky to find someone like you, who then uses the right tools to help.
Exactly.
Because instant help
makes all the difference.
Makes the difference. Why is that actually? What would happen if he wouldn't have come instantly?
You mean my patient?
Yes.
So what can happen is if he hadn't come instantly, say delayed it, he would have ended up permanently deaf in that year, because you lose the golden window period, and this after a point the steroids don't work. If he had come say a week later, he thought, let it pass, maybe I'll hear it better later, and he had come a week later, we would have still offered him the treatment, but I wouldn't have been able to give him a guarantee that his hearing will come back, because he missed the golden period. So that makes all the difference.
Yeah, and why would you not be able to guarantee that the hearing comes
Because the nerve would have probably already gone for an irreversible damage, because the edema has been there for a very long time now. Yeah. So,
So what we call edema is swelling. This is just like it's some kind of a tissue that suffocates the other tissue.
Exactly.
So that the other tissue gets even less nutrition and then dies.
Yeah.
And that's of course with the ear is one of the most sensitive organs that we have, the inner ear.
Yeah.
And the inner ear is very
complicated.
And especially also so sensitive that it really easily gets damages.
Yeah. True.
Although this is also a genetic thing, some people have very robust ears.
Exactly.
Some people
don't. Exactly.
Okay, Yeah, this is a very interesting case,
Yes.
and I'm happy that you shared that with me. I
My
didn't hear
pleasure.
about this. This is really good to
Yeah,
hear.
yeah.
So I hope for your patient that he will get his
Yeah.
full hearing back.
Hope so too.
And did you give any other medicine along with that, like vitamins or
Yeah,
anything?
he was given a combination of vitamin B, that is basically B1, B6, and B12. That also helps with the ears. These basically act like vasodilatation along with the steroid. So steroid causes, as you told, anti-inflammatory. Along with that, these vitamins help in increasing the blood flow to the inner ear. So he was given a B complex, that's B1, B6, and B12 as well.
Wow.
Yeah.
So this is the so-called B complex.
B complex, yes.
Which is very good for nerves.
Yes, exactly.
Anything else that you give, like ginkgo or so?
Ginkgo, he has been taking it already, so I didn't have to put him on that, because other than hearing, ginkgo is also used as a brain stimulant, so for memory purposes and all of that. So he said he's been on that since he was a child, so I didn't have to add him on that.
I need to tell you, in Germany, we had for a long time a different strategy.
Okay.
We were thinking that blood circulation is the main thing to provide.
Right.
And we were giving our patients plasma expander.
Yeah, dextran, right?
Yes.
Yeah, yeah.
We're giving this hydroxyethyl starch.
Right, yeah.
Which is basically a solution of molecules that are extremely big.
Yeah.
And big molecules, they attract a lot of water.
Right.
And if it's like if you have salt in your cabinet, and the salt attracts the water from the air.
Yeah.
These molecules, they attract the water from your cells, and then you get more blood volume.
Exactly.
So how many liter blood do we have usually? 5-6 liter or so.
Yeah.
So when you put half a liter hydroxyethyl starch in the body, then your volume increases by 1 liter.
Yes.
Or more.
Depends,
And it had to be given in very slow drips, and people are taking these drips every day and for 2 weeks or so.
Exactly.
We got some slight improvements there, but not
complete. There have also been studies where people were using pentoxifylline along with dextran as well.
Yes.
But unfortunately, it's not available now, pentoxifylline, in the market anymore here.
Really?
Yes. So I've given it for a couple of patients, and they told they've checked all over the pharmacies, and then when I spoke to the authorities, they said it's not available here anymore. So that was also given initially, pentoxifylline, as a combination with the drugs, but
Pentoxifylline is another medicine that is quite smart. It makes the red blood cells a little bit more slippery, that they can go through the capillaries and reach with their oxygen load to the cell.
Exactly.
Why is this on the market anymore? It's strange. Yeah, all right, good. So that was exactly our combination. It was called the standard combination.
Yes.
Did you hear about
the standard? There's a standard protocol for facial palsy as well.
Exactly. It's similar to that.
Similar to that, yes.
Yes. So he's from Cologne. He was a professor in Germany.
Yeah.
I don't know if he's still alive.
Not sure too.
Anything else to say to this topic?
No, I think we have covered most of it.
We've covered it.
Yeah.
So stay tuned with us. Next time we present another case.
Another interesting case, yes, for sure.
Thank you, Swetha.
No problem, my pleasure.
Bye.
Bye.